Salam everyone. This is part 2 of the whole body inflammatory response to cardiopulmonary bypass machine. I will start with the arachidonic acid cascade. Arachidonic acid cascade. The lipid membranes produce the arachidonic acid, which can be inhibited by corticosteroids. Arachidonic acid converts to leukotrienes and endoperoxidase with the help of COX-2, which can be inhibited with non-steroidal anti-inflammatory drug acetaminophen and aspirin. Endoperoxidase change to prostaglandins, prostacyclins, and thromboxane, which decrease vascular tone, increase pain, increase uterine tone, and increase temperature. Thromboxane increase platelet aggregation and vasoconstriction. Leukotrienes causes bronchoconstriction, and that can be inhibited with zafirlocas and montelukast. And it also produces neutrophil chemotaxis. Leukotrienes promote plasma leakage and leukocyte adhesions. Leukotriene increases during and a short period after the cardiopulmonary bypass machine. When there is an increase in leukotriene, there will be more inflammatory response and more cytokines produced, including interleukins. Interleukins promote more inflammatory response, and that will stimulate the tissue necrosis factor and the leukocyte adhesion molecules. The tissue necrosis factor will increase vascular permeability and thus increasing the space between the endothelial cells. And as a result, that will lead to interstitial edema. Now we will go to the protein denaturation, but here the camera is not fixed, so I'm sorry for that. Protein denaturation happens because of the blood-gas interface. The blood-gas interface is more with bubble oxygenators, and it is less with true membrane oxygenators. Protein denaturation occurs on albumin, which gives non-specific effect, while for the immunoglobulin, when it is denaturated, it stimulates the complement cascade. Metabolic acid-base status. Usually, during the cardiopulmonary bypass machine, there is metabolic acidosis, even when there is adequate blood flow. This is because of uneven blood perfusion. There are some areas that doesn't get enough blood, and that will cause lactate production by these areas. But the metabolic acidosis is not severe, and it rarely exceeds 5 millimole per liter. Then we have hemolysis. When there's complement activation, C5b9 will be produced, which attaches to the surface of the erythrocytes, and this is one of the major causes of hemolysis during the cardiopulmonary bypass machine. Systemic vascular resistance and arterial blood pressure. During rewarming, when there is significant decrease in blood pressure less than 40 millimeter mercury, we should rush to the pharmacological agent, the vasoconstrictors, because however we increase the Q, which is the flow from the pump oxygenator, which is measured in ml per kg per minute, this is insufficient. We should give the vasoconstrictor. And also when it is higher than 100 millimeter mercury, which means we have high systemic vascular resistance, we should give pharmacological agents. Now we have the vasoplegic syndrome. Despite high cardiac output and adequate Q during the cardiopulmonary bypass machine and adequate fluid perfusion, still there is low systemic vascular resistance. So that means low systemic arterial pressure, and patient with significant low MAP after cardiopulmonary bypass initiation are at risk for developing of vasoplegic syndrome or die in the hospital or prolonged stay in the hospital. For treatment, we can use vasopressin, which will increase the blood pressure and decrease the catecholamine. Methylene blue also can be given for cases of vasoplagic syndrome which are resistant to vasoconstrictors. Risk factor for developing this syndrome. When preoperatively the patient take ACE inhibitors and beta blockers. Low ejection fraction. When we use vasopressors or aprocitentan before the cardiopulmonary bypass machine. And the other one is low pre-cardiopulmonary bypass machine mean blood pressure. Then we have longer length of the cardiopulmonary bypass machine and higher temperature during being on the machine and higher pre and post cardiopulmonary bypass machine hematocrit. Then we have the distribution of blood flow, regional and organ blood flow. Many factors affected, including the age of the patient, hemodilution, pharmacological manipulation, and temperature. Also, the arterial CO2, O2, and pH level. Then we have the cerebral blood flow. During the blood perfusion during this machine is non-pulsatile, and the flow is about 1.6 liters per minute, and the temperature is about 25 Celsius. The need of the brain tissue is measured by radioactive xenon clearance. So each 100 gram of brain tissue will need 25 ml per minute, and during normothermic and moderately hypothermic cerebral blood flow is not significantly altered with variation of cardiopulmonary bypass. Then we have the cutaneous blood flow. The blood flow to the skin is decreased. That's why the complications are small bald spots on the back of the head and bands easily produced by coterie. But then we have the microvascular alteration, which is affected by peak lactate level, and this finding is not specifically correlated to the machine. Catecholamine response. We have sympathetic adrenal system discharge. From the adrenal medulla, it will secrete epinephrine, and from the brain through the sympathetic nervous system, norepinephrine will be secreted. Then through the lungs. During cardiopulmonary bypass machine, no blood flow through the lungs, so the lung will not deactivate the norepinephrine, so the level of norepinephrine in the blood will be high. This machine have massive effect on catecholamine release, and it starts to decrease when the patient is disconnected from the machine, but in hypertensive patient it will stay high for 1 hour after the machine. Venous tone. Venous constrict during this machine and increase the tone for several hours due to the effect of catecholamine. We have adrenocortical hormones. There will be increase in cortisol and adrenocortical hormones after initiation of this machine, and it will stay high for 24 hours. Vasopressin or antidiuretic hormone secreted by the pituitary gland and regulator of renal water excretion. This increase in ADH can persist early postoperatively. Then we have the body composition. There is increase in extracellular fluid volume, and that depends on the duration of the machine, which is greater with hemodilution, hypothermia, and higher CPPQ. About the exchange, there will be more exchangeable sodium after the machine use, and there will be decrease in exchangeable potassium and decrease in intracellular potassium. These acute changes are the damaging effect of the machine, increased capillary permeability and body composition. Thermal balance. Heat is lost during the machine, and the temperature in muscle and fat is less than that of the nasopharynx, and after CPB there is hypermetabolic state for 6 hours. Thank you for watching, and I hope that was informative.